Hello and welcome to What Women Want Today podcast, season 3, the Soul Sister series, where we will tackle tough topics straight from our heart to yours. I'm Terry Kellums, your host and coach for women who struggle to find meaning and fulfillment in midlife.
I am Amanda Keeper. I am your new regular contributor. I come straight from the Midwest, Rockford, Illinois. I'm a public speaking teacher and leadership development professor. I'm also a coach and clinical mental health counselor. I am so thrilled to be here, and let's get started.
Let's do it. Hello and welcome to this week's episode of the podcast. I'm your host, Terry Kellums.
Hi there. I'm Amanda Keeper, your co-host for today. Excited to be here.
Amanda, are you as excited about interviewing Dr. Michael Green as I am?
I don't know. How excited are you?
I'm very excited.
Yes, I concur.
This is one of my very favorite topics, and I'm so glad to have Dr. Michael Green, Chief Medical Officer of Winona, on the line with us today. Welcome, Dr. Green.
Thanks. I'm really happy to be here too. I'm excited as you two.
Good. Did I pronounce it right? Winona?
Winona, correct.
Good.
Yeah.
Great. Well, Dr. Green, do you want to start off by just giving us a little bit of background about how you went from, I know you started out as family practice, and how you worked through your career and got to be the Chief Medical Officer of Winona.
Sure, I'd love to. So I came out of medical school and I thought I wanted to do family medicine. I'm kind of a buffet kind of guy, and I was like, well, I want to do a little bit of everything. And when I got through my family medicine residency, it kind of hit me that I really didn't like taking care of sick people. It was kind of depressing. And I love delivering babies. And women's health was really kind of a passion for me. And people around me were surgery attendings, and the gynecologists were telling me that I had really good surgical hands and I was wasting my talent. So I did a whole second residency after becoming board certified family practice in OB-GYN. And that's pretty much what I've done my whole career. Yeah. So I spent 17 years, raised our kids in Ventura, California, doing sort of full scale OB-GYN practice. Then I took a job, it was more of a lifestyle change as an OB hospitalist, which is, I'm still doing now, although Winona started sort of as my side gig, and now it's kind of taken over my life. So I've kind of done a lot, I'm doing a lot less of the OB hospitalist. And then I live in a small town, so I see patients, we have a little rural health clinic. I see patients a couple half days a month here, basically part of the community. So that's sort of what I'm doing now. Winona was interesting. It's my son's company, him and his 4 business partners. Maybe a month before COVID, it was like January before COVID, we had a conversation about doing a telehealth platform. And we were kind of talking about, they were picking my brain about different ideas. And maybe 9 months later, they asked me to come on as an advisor, and then eventually Chief Medical Officer of Winona. It's been an amazing project ever since. So that's kind of how that all worked out.
Well, when I learned about Winona, one of the things that jumped out at me that I was so impressed with and that really excited me was that it's plant-based HRT that you're offering. How is that different from a woman just going into an OB's office that doesn't, maybe specialize in it, or it doesn't have a lot of interest in hormone replacement therapy? What would be the differences?
Sure. So the sort of classic hormone replacement therapy are 2 medications called Premarin and Provera, Premarin being estrogen and Provera being the progesterone. And all the big old studies were done with those 2 hormones. Premarin actually stands for pregnant mare urine, and that's exactly where it comes from. So they have all these pregnant horses, they collect their urine, and they collect all the estrogens out of them. And some of them are what humans make, but a lot of them are unique to horses. There's I forget the exact number, but in the teens of different estrogens in this. And it's sort of put together in a pill or a cream, depending on how they do it. And so it works well, but it doesn't work great because there's all these hormones that aren't exactly really what the body makes. There's also synthetic hormones that are made. So basically they just take chemicals in the lab and turn them into, hormones that are close, but not exactly the same. And they call that biosimilar hormones. So it's similar to what the body makes, but not exactly the same. So bioidentical hormones are chemically identical to what the body makes, and ours are plant-based. And these are, so when your body sees these, it's exactly what it's used to. And so most of us think that they work better and have fewer side effects because they are exactly the same thing as what the body makes.
So, doctor, when a woman comes into the clinic and she is describing what she's going through, what will you often hear her talk about?
So the most common or sort of famous symptoms are hot flashes and night sweats, and that's can be pretty disturbing for people and cause a lot of problems. But there are it's amazing how many women don't have that symptom but still have menopause symptoms. So sleep disturbances are very common. Brain fog, where you feel like you're half a step behind, maybe can't quite pull someone's name when you normally could, things like that, are very common. Weight gain is probably the most disliked symptom of the menopause transition. And what happens is the weight tends to accumulate around the middle when that never used to happen. And the things that used to work when you gain weight aren't working anymore. So you're exercising and you're eating right, and the weight just keeps accumulating around the middle. And that's also a sign of the menopause transition. There can be also a lot of vaginal changes, vaginal dryness, irritation. That can cause bladder problems. It can cause pain with intercourse and just irritation throughout the day. And those are common symptoms as well. There's also skin and hair changes that we see, general fatigue. People just don't feel as well. And there are some women get joint pain that is caused by this. So it really, there are estrogen receptors all over the body. And so when the estrogen's not coming out right, not enough or not consistently, it can really throw things off pretty much everywhere.
I think this kind of sneaks up on women. And here's why I say that. We go from all the pregnancy things I'll start even back just a little bit further than that. My youngest daughter has horrible time with her menstrual cycle, lots of pain, just lots of symptoms. And then we move into our childbearing years and the raising of those children and still maintaining our home and having a career. We feel like shit a lot. And so I think perimenopause kind of sneaks up on us because we already don't sleep well. We already have a lot of unexplained body pain. Help me out here, Amanda. You're younger than I am. You're still going through perimenopause.
You were speaking my language when you were describing all of those symptoms. I mean, I'm 47, and the most troubling part for me is all the weight gain around the waist. Yes. When I had like the flattest stomach for years, and now I'm like, what is happening to my body? And yes. I feel like inflamed. My body feels inflamed.
Yeah. So that's why I say I think it sneaks up on us a little bit. And maybe a lot of women are experiencing these things in perimenopause and don't even really realize it, because what would be the average age that you see that this is starting to become a problem for women and they're coming to seek medical advice or care for it?
Yeah, that's actually one of the things that makes it sneak up on women, is that I think it starts a lot younger than people give it credit for. So if you look at just statistics, about the average woman in the United States completes menopause at about 51, but symptoms tend to start 7 to 10 years before menopause is completed. And the surprising thing is 15%, about 1 out of 6 women, complete menopause by 45, which means if you go back 7 to 10 years, we're talking mid-30s.
And they've still got growing children at that point.
They've got little kids at that point sometimes. Yeah. So yeah, it's a surprise for women, and honestly, a lot of doctors don't really understand this. And so, they're 30, 38 or 39, and they go to the doctor and it's like, well, you're too young for this to be menopause, and so they kind of blow it off. And I think a lot of women feel the same way. Well, this can't possibly be that, so they don't even consider it. But it's actually quite surprising how common it is, late 30s, early 40s. And, unfortunately, nobody really gives that credit. And so people don't get the treatment that can help.
Well, and there's a stigma, right? I mean, menopause is like, I don't know, I'm going to be dramatic here for a second. It's almost like the death sentence for a woman, because when our mothers, the ones that talked about it, which I don't think a lot of women my age, our mothers, they didn't really talk about it. But when you did hear little snippets of menopause, it was awful. It was dreadful. And so, I remember going to a little gathering with a group of women that were quite a bit older than me, and they started talking about it, and I left there thinking, God, I don't ever want to hang out with those women again. That all sounds so depressing, but the truth of the matter is if we don't talk about it, and if we don't have guests like you on our podcast educating women, then we're stuck with a lot of women who go through life feeling terrible and having it affect their relationship with their husband, having it affect the way they feel about themselves. Because, just like Amanda said, I didn't really have a weight problem, so to speak. And then it just happened overnight where all of a sudden the things that I could do before, I'm an exerciser, I eat healthy, they weren't working anymore. And so, I feel like it kind of piles up on us in midlife, because now we're facing, we're facing the empty nest, we're facing body changes, we're facing the way our relationship may be with our husband. And why do you think I don't know, I feel like there's two movements out there kind of butting heads right now. There's the movement where there's a lot of women out there pro HRT. Come on, ladies, let's get on board with this, seek medical attention. This is not a bad thing. And then there's the women that say, this is just natural. This is what our bodies are supposed to do at this time of life. What do you think about that?
So yeah, I mean, that is absolutely true. I've never understood the "this is natural" argument, because natural doesn't necessarily mean good.
Right.
I mean, nature's pretty mean, and as a doctor, honestly, what we do is try to beat nature. It's like, gee, nature says 15% of women should die in childbirth. Like, well, that's not good. Let's fix that.
Right.
Nature says, women are going to suffer through this period, this transition period. Well, why? When we can fix that and make it better. Nature, it doesn't necessarily equal good. Nature's pretty mean.
Mm-hmm.
And so I understand people making that argument. I just don't think it's a great argument personally. But again, my career has been devoted to trying to make things better than what nature wants to do. So, I'm biased from that point of view. But I agree, it's an interesting, this sort of, well, tough it up, this is part of life. It's kind of a harsh thing to do, especially when there's treatment.
Yeah.
There's some things there aren't treatment for, and then it's like, okay, we got to figure out how to get through this as best we can. But there are other things like the menopause transition that there's really safe and effective treatment for. Why not feel better?
Yeah, I agree.
So that's where I want to follow up. I'm a researcher by nature. And so can you tell me about how you really dove into the research, who you were following, and what kind of tracking are you doing of the success rates of the product?
So yeah, let's start kind of with the basic research. I'm old enough that my career has spanned the pendulum. So I was practicing before the Women's Health Initiative study, when we were giving hormone replacement therapy to everybody. Mm-hmm. And at the time, appropriately, based on the research we had, but in hindsight, inappropriately. When the Women's Health Initiative study came out, it scared everybody, and people just stopped everything, which was a total overreaction to that study. And so as people started looking more carefully into that and more data came out, we realized that, the data doesn't say that hormone replacement therapy is unsafe. It says it's a medicine like everything else, and you've got to do a risk analysis and make sure that you're doing it correctly and safely. And when done that way, it's very safe. And so there's a lot of data that has come out now that guides us in how to do this safely. And so it turns out, if you look at the data overall, if you start women on hormone replacement therapy before they're 60 and they're an appropriate candidate for it, they actually have a longer life expectancy and they live a healthier life than women that have never been on hormone replacement therapy. Wow. So when done correctly, it's very good for people, not just for their symptoms, but for their long-term health. And I think that is slowly becoming more accepted and realized as people understand what the data says. Okay. I can tell you that I did a ton of research when we started Winona. I was reading everything I get my hands on, because honestly, as a generalist OB-GYN, we really do very little menopause management. Most of our time is spent with pregnant patients, or writing birth control prescriptions, or doing surgery for women, and relatively very little of our time is spent doing hormone replacement therapy. So none of us get really good at it when you're sort of a generalist OB-GYN. So when it was like, okay, this is going to be my responsibility, then I really did a deep dive and started reading, everything I could, and realized, how misinformed I was about what's the right way to do it, what's safe, what's not safe, what are even some of the symptoms of menopause that I wasn't recognizing, the age thing we already talked about. And so, that continues, obviously. And we monitor our patients very carefully to make sure that things are safe and working and not causing problems. We just had, so I just had a meeting with our doctors. It's like, hey, just want to make sure anybody's seen, this problem or that problem, or anything that anybody's seeing as a pattern, because we want to make sure that there isn't something that we missed or that's inadvertently. And so far, so good. We've been, so April was our 2-year anniversary. We've had tens of thousands of patients, and we haven't seen any problems that would be outside of, what you would expect statistically. There's been some tragedies, a couple of patients dying in car accidents, that kind of thing. Life happens. But we really haven't seen anything that really was outside of sort of what you would expect for the normal experience. So I feel very good that what we're doing is safe and effective.
Thought I'd heard at one point they did. I'm sorry, Amanda, go ahead.
I was just going to say, thank you for that detailed explanation. And also, I wonder, coming from a background, and this is a very personal question, of a mom who died at 62 from stage 4 ovarian cancer, and found it, obviously, as you know about ovarian cancer, very, very late. It's one of those hidden things that people don't find. Is there a connection that you found in your research between hormones and cancer?
So yeah, that's a great question. So assuming somebody doesn't have one of these genetic markers for female cancers, there's several of these, the BRCA gene, or like the Lynch syndromes, those kind of things. So taking those people out, it turns out that a family history of cancer actually does not increase risk with hormone replacement therapy, even a close family history. On average, if you look at cancer and hormone replacement therapy, it's a little nuanced. So there is it's actually kind of interesting. For women that have not had a hysterectomy, so they're using both estrogen and progesterone, there is a slight increased risk of breast cancer. But there's a decreased risk of colon cancer. When dosed correctly, there's a decreased risk of uterine cancer. Ovarian cancer, sort of neutral. And the big thing, though, is that the cardiovascular risk goes way down. And so that's why, in balance, when you look at the full picture, women on hormone replacement therapy live longer than women without it. And so I think, you can always sort of pick and choose depending on what argument you're trying to make, and say, well, it's an increased risk of breast cancer, so women shouldn't be on it. Oh, but it's a decreased risk of colon cancer, so women should be on it. But to me, what do we want out of life? We want to live longer, healthier lives. And this helps you do that when screened appropriately. So that's kind of the way I look at it. But yeah, the family history thing is actually fairly surprising. Again, once you take those genetic markers out of it, really the data is pretty strong that even a close family history, even of a hormone-sensitive breast cancer, really shouldn't stop somebody from taking hormone replacement therapy.
Thank you.
Yeah.
So I am currently doing HRT. I do the bioidentical pellets.
Mm-hmm.
So my husband asks me this all the time, and I never get an answer to this question from my doctor, but how long can one expect to stay on hormone replacement therapy?
Yeah, that's a great question. So it's honestly safe to be on as long as it's relieving symptoms. My personal opinion, and I think that of sort of the consensus opinion, is that in general, it's best to be on the fewest medicines and the lowest dose of medicines that is necessary to achieve your goal. So, sometimes for some women, there comes a time when it's no longer necessary. And so at that point, there's no point taking it. The average woman's on hormone replacement therapy for about 5 years.
Okay.
So my recommendation generally is, after you've been on it for a few years, things are going well, it may be worth doing a trial off of it. So, go off of it for a couple months, see how you feel. If you feel the same, well, you don't need it anymore. If you don't, go back on it. And I always say, be careful about your time. Don't do this before your kid's wedding or something. You want time in life that's reasonable.
Good advice.
But But I mean, I think that's a reasonable way to do it. The body is, it's very sensitive, and it's the best thing we have to really test how these hormones are working. And so a trial off of it at a time in life where, okay, if you're a little uncomfortable, it's not going to be, it's not going to add to some horrible stress you're already under, I think is a reasonable way to do it. And if you don't feel any difference, maybe it's time to be off.
Well, I was scheduled to have a surgery. And when my doctor heard that I was doing the pellets, he asked me to go a cycle without them.
Mm-hmm.
And so by the time I went the cycle without them, had the surgery, went through the recovery, my husband actually asked me to go back on them.
So there's your answer.
So I'm going to say I still need them. So, I found a significant improvement in my symptoms, and I am an advocate. I know that women, are going to make their own choice. We're just here to educate and, offer resources. So can you tell me a little bit about how you administer them? Is this in a pill form, a patch form? Like, how are you helping women? And can you do it outside of California or only in California?
So we just added our 21st state. The first, we added Idaho. So we're in 21 states. We're trying to our goal is to be in all 50 states a year from now. But our 21 states cover over 2/3 of the US population. So we're getting there. And it really has to do, each state has different rules and laws. And so obviously we have to do things correctly. And we also have to be able to ship there. So there's pharmacy laws, there's medicine, it's fairly complicated. So I work with our pharmacy folks, and we kind of look at the legislation, what needs to be done. Idaho is interesting. We actually successfully lobbied Idaho to change some of the rules so that we could work there. So those went into effect July 1st. So that's why we started there. So that's the are we outside of California answer. And I'm sorry, I had the first half, which was the more important half. I just lost.
How do you administer? Is it a patch?
Oh, administer it. That's right. Sorry. So we have choices. So we do pills, patches, and we do compounded creams. So the pills are sort of probably the pills and patches are pretty traditional. So the pills, you would take a pill every day. The patch you put on and you change it twice a week. If you need progesterone, you would take a progesterone pill along with the patch. The cream is compounded in our pharmacy. So we have our own compounding pharmacies, one in Idaho and one in California. And so those creams are made specifically for the patient's needs. And they can be estrogen or progesterone or a combination of estrogen and progesterone. And it's a little amount of cream that's rubbed usually into the inner arm. But there's different places that can be placed, and that's done once a day as well. So those are the different options, and really they all work well. Mostly it comes down to sort of personal preference, cost, that kind of thing. But occasionally you'll have somebody who, for one reason or another, and I don't really understand why, seem to respond better to one over the other. So sometimes we'll have somebody on a pill and it doesn't seem to be quite doing it, and we'll switch them to the cream and it works better, or sometimes vice versa. But for the most part, my experience is most women will respond well to any of those modalities, and they're all pretty easy to do and to use.
So you were saying if a woman is a good candidate, what is the screening process like?
So we have an onboarding, what's called an online adaptive interview, that basically asks probing questions, and the questions will change, depending on the answers. And it's really, so this was interesting. So I designed this, and it really, for me, it was I had to change my thinking pattern to design this, because, when you go to a doctor's office for the first time, they give you a big book to fill out of like everything, and that's sort of what I was used to. And I realized this is just too cumbersome. And it's like, do I really need this information? Like, I don't need to know if you sprained your ankle when you were a kid to safely provide you hormone replacement therapy. So the idea was really to wean this down, ask everything I really needed to know to do this safely, and nothing else. And so that was a process. And so the onboarding really is designed in some ways to kick you out. So I want to make sure safety is our safety is our most important thing. If I relieve your hot flashes, but I kill you, I haven't done you any good. So that's absolutely the most important thing. So, we ask age, gender, certain medical conditions that would be unsafe. If you've got, a serious heart condition, if you have uncontrolled high blood pressure, if your blood pressure is controlled, that's fine. If you have a history of blood clots like a DVT or something called a PE, or a condition that puts you at higher risk for that, that would be a reason not to use it. If you have an active liver disease or a serious liver problem, that would be a reason not to use it. So it's all these different questions to make sure that your medical history is safe and you're a reasonable candidate for this. We also obviously then we ask your symptoms, and we show you options. Pills, patch, cream. Kind of here's the advantages, disadvantages. See what you want. And then I have an algorithm I developed. It took me about 1,000 patients to really nail this down. That then puts out this is the recommendation, and then if that looks good for the patient, they say, yeah, this is something I would like. Then that goes to the doctor. The doctor reviews it. Sometimes follows up with some questions they might have, or if everything looks great, goes ahead and approves the prescriptions. Those go to our pharmacy and then get mailed to the patient. So it's a really convenient way. Nobody ever has to leave their house. It's convenient, and the nice thing is it's convenient for the patient, but it's also convenient for the doctors. So we can do this in between patients, or get up in the morning over your morning coffee, kind of see the patients from overnight. And so it makes it a nice way for the doctors to practice medicine as well, which I think is also important. And that's something, quite honestly, that's been going away quite a bit in healthcare. So the idea was to try to design something that's both patient friendly and doctor friendly to, make this work best.
Yeah. Awesome.
So you didn't say it, but I kind of heard you saying insurance companies there. When you said doctors' lives aren't so easy, that's what I heard you say was insurance company. But speaking of insurance companies, is your product covered by insurance companies?
So we don't do insurance. However, we do take HSA and FSA cards.
Sure.
So a lot of patients use that. And then some patients will build the insurance directly themselves and have had success for that. So it really depends on the insurance and deductibles, and there's just so many plans. But we don't sort of take insurance in that manner. But a lot of
probably helps keep your costs down a little bit too, right?
That definitely helps keep the cost down. And that's one of the things. That's one of the other things. We try and do this as efficiently as possible because we want to keep costs down. And make this as affordable as possible for people.
Yeah, because pellets definitely are not cost effective.
They're not cheap, that's for sure. But if they work well for you, it may be worth the cost. But,
yeah, it's worth it for now.
This should be significantly less expensive than pellet therapy, I would imagine.
So you didn't mention testosterone in there. So part of my pellets is estradiol. I can't remember how to pronounce it.
Yeah.
And a little bit of testosterone, but you don't prescribe testosterone as part of your therapy?
So the problem is testosterone is a controlled substance. And so legally, we can't prescribe testosterone in the way we do telehealth.
Gotcha.
However, we use a supplement called DHEA, which is also a bioidentical hormone. And DHEA gets broken down into estrogen and testosterone really within 30 minutes of taking it. The estrogen is pretty minimal. It's the testosterone that we're really after, and DHEA will raise testosterone levels. So that's how we give women the testosterone they need. It's sort of an indirect way to do it legally. The other nice thing about DHEA is an interesting medicine, really. DHEA is a performance-enhancing drug. So you see bodybuilders and other athletes using these ridiculous quantity, not ridiculous is the wrong word, but very high dose quantities or dosages of DHEA. And in those dosages, it can cause significant side effects because it works. And it can really raise testosterone and cause these testosterone side effects. So we are really careful, and we don't prescribe above 50 milligrams. So mostly we start at 25 and we go to 50. And at that dose, it's enough to get your testosterone sort of to normal female levels, but not enough to push it into sort of athlete levels. And that's really what we're after. So we're not, we're not prescribing this as a performance enhancing drug or that kind of thing. We're really just trying to get people back to where they should be normally, so they can feel better. And the DHA works quite well for that. So that's how we do our sort of quote testosterone. It's also when you're using, testosterone injections or testosterone cream, testosterone levels really need to be watched because testosterone's tricky. And it's pretty easy to go overboard and cause problems. With DHEA, as long as you stay 50 milligrams or less, you really don't need to do that. So it makes it a lot more simple for the patient. And again, affordable because blood tests are expensive and they're kind of a hassle.
So DHEA is over-the-counter supplement.
DHA is a over-the-counter supplement. We do provide it. We treat it like a prescription through Winona. So, someone can't just kind of go on and order DHA. Everything wants, again, just as a safety feature, we want everything to go through the physician. The interesting thing, which I think is really cool, I'm kind of proud of, we've gotten big enough that we prescribe a lot of DHEA. And so we're ordering pills in millions of quantities at a time. And because of that, we have a lot of control over the manufacture of this. So we have, our sources are basically doing runs just for us. And so we can demand what we want. And so we know that our DHA is really high quality. We're able to demand a really small capsule to make it more convenient because of the volume we're doing. It gives us a lot of control, which we like. And we think that it's sort of a safer way to do it, especially with a supplement, because there isn't the same quality control with supplements as there are with the pharmaceuticals. So this gives us a lot. It gives us more control, and we know with our DHA what women are getting, and that it's really the real thing, and it has what it's supposed to have in it. So that is one advantage. But certainly DHA you can order it on Amazon as well.
Mm-hmm. Yeah, I always worry about that when you're ordering supplements or any supplement that you take, whether it's DHEA or magnesium. Like how much of it is actually bioavailable to your body?
Exactly, right. And that's a big question that with the pharmaceuticals, the FDA treats them in a whole different way, and there's a lot more oversight and supervision. But with the supplements, it's kind of a lot more loosey-goosey, and so there can be a lot more games played, unfortunately, with what's being supplied.
Amanda, I don't want to keep interrupting you.
Oh, you're fine. I'm just going to switch gears a little bit to you as a professional. Like when you gave the last examples, your eyes lit up like a Christmas tree. So as we go through our careers, our purpose changes. Like what is your purpose in this season of your career right now? What brings you career bliss?
So Winona has been amazing. It was this sort of surprise thing, and it's just turned into this incredibly cool thing. So to start something like this from scratch and get to where we are now, and really, we make such a difference in a lot of women's lives. It's funny, we all have bad days. So my docs, I'll tell them if they're having a bad day, I'm like, go on Trustpilot and read a few reviews. That'll make you. I'll give you that good feeling inside that we make. Sometimes we forget what a difference that we make, and it's been incredibly rewarding. It's also, I've never done anything like this before, and apparently, I guess success says that, but apparently I have some skills that I didn't realize I have in running and growing a business, and I have. The amount of stuff I've learned, not just medicine, but business-wise in the last 3 years, I love to learn, and it's just been an incredible experience. And so for me, this has been great. And then the other nice thing about it, quite honestly, is that I was doing 8 to 10 24-hour shifts a month in the hospital. And now I'm only doing 2 shifts a month, and I'm honestly probably spending much more time working, but I'm doing it from home. So my wife of 35 years and I, we get to go, I run errands with her, or we'll we'll take a walk in the forest or whatever, and then I can get back. And so it's been, for me personally, this has been a really, really great season of my life.
Yeah, I was picking up on that. I was picking up on the skill of the medicine and being a doctor, but also adding in the entrepreneurial side of you and the creative side. And so I was expecting that answer. And I think that's super exciting for our listeners too, to let them know and remind them, like, as we grow and transition in our lifespan, we can redefine our careers and find some agency so we find more joy and do what we love, but have more time with our families, which is really cool.
Love that.
Yeah, it's been great for me.
So if our listeners are tuned in today and they're on the fence, about HRT, maybe they should just go get the synthetic from their OB-GYN or maybe reach out and work with you. Like, what advice would you give to these women?
So do something. What do we say in the operating room? That the enemy of good is better. And so if you're more comfortable seeing your doctor in sort of a brick and mortar traditional sense, and that's your comfort level, do that. But don't, and then if you get sort of quote blown off or whatever, then maybe explore another option. If on the other hand, this sounds like a more convenient and a comfortable way of doing that, this is a very safe way to do it. And so, go online, buywinona.com or one of our competitors. But don't not get yourself feeling better because you're sort of afraid of the process. I think there's no reason to suffer through this. You might as well feel the best you can.
I love that advice. I will add my unprofessional advice, but just as a professional podcaster, if you walk in there, excuse me, and tell your doctor that you're having these symptoms, you can't sleep, and he hands you a prescription for an antidepressant based on those few symptoms alone, I think you probably need to seek some other opinions on that. That's just been my experience. So that's my 2 cents. Amanda, you got anything to add to that?
Just that if he or she hands you an antidepressant.
Oh, yeah, that's true.
We have a lot of fantastic female doctors.
Sorry.
It's my training. I have to say it. It's my training.
No worries. So Dr. Green, where can people sort of like find out more about you? I know you have a YouTube channel called, see, I wrote it down here, Med Twice, which there are lots of videos on there that were very interesting. You have a Facebook group called Winona Women. And I understand you are doing some bi-monthly webinars for free if they're if they're inside your Winona program?
So so I'll back up. So Med Twice actually is kind of interesting. That was a project my son and I did years and years ago. It's not really HRT focused. It's mostly
okay.
OB. And he got frustrated online because he's like, there's all this stuff, but how do I know that it's real advice? Like, who's doing this? And so we made these little videos of me explaining stuff. It's just like 250 videos.
Yeah.
But mostly it was OB because that's mostly what I was doing. And you can kind of see me younger back then. And we didn't really promote it, and it became actually a fairly successful YouTube channel. It's kind of funny. But that sort of still lives, but we haven't touched that in a long time.
Once it's on the internet, it's always there.
But it's been helpful. It was funny. Last year, I was covering for another doctor. I ran in to do a delivery because they weren't making it in time, and she's, "You're the YouTube doctor." And I think she was more excited that I delivered. I was like this big celebrity delivering it. It was kind of funny. But so yeah, that is a place to go. But we don't have a lot of HRT. So on by Winona, we have a very large patient education section. I've always felt that my primary role is an educator. So my job is to educate people about various options, what I think they're going through, my advice, but here's ways to do it. And then the patient has to decide, what's going to be the right match for them. And so we've really done that, I think, well on our site. So there's a huge library of blog articles, all sort of referenced, to show the scientific, merit to what we're talking about. There's also a lot of videos, so depending on the format that you're interested in. We do 2 live Q&As a month. One of them is primarily for existing customers, and one of them is for what we call prospects. People are thinking about this, but have questions. So, and the reason that we do it that way is the questions tend to be different. we do have some crossover. We don't say you can't come on unless you're this, but that's sort of the emphasis, because the questions when you've been on it for 3 or 4 months may be different than the questions when you're considering it. So we do that, and usually myself, Dr. Kat Brown, also she co-hosts, or sometimes she does them, kind of depending on our schedules. And so we spend about an hour. People put in their questions and we answer them in a live format. So we try to reach out. Our Facebook group is very active. That's moderated, but not by the doctors. We purposely kind of don't want to do that. We want to let it be really a peer-to-peer discussion group. Occasionally there's crazy stuff we take down, but not very often. So, if people start getting mean or abusive, we take that stuff down. Or if somebody's quoting stuff that they can't back up, that's crazy, we take that down, because we don't want misinformation out there. But for the most part, we let it be a peer-to-peer discussion. That's been very helpful for a lot of our patients. So that's another avenue. We've tried to kind of, as many different ways as we can think of, because people, learn different ways. We try to supply education for patients or prospective patients.
Any Instagram channel that you have, or no?
Yeah, we do. And honestly, I don't, I'm embarrassed. I don't know the handle or the name or whatever it's called for the Instagram channel, but I'm sure if you search by Winona in Instagram, it'll pop up.
You'll find it. She's really good with that stuff. So let me ask you, just out of curiosity, how did you name the company?
So the company was named actually before I sort of was brought back in.
Okay.
It's named after it's a Native American name. I forget which Native American language now.
Okay.
That basically is strong daughter, strong woman.
Oh,
love that.
Awesome. I'll have to look that up.
Well, Dr. Green, thank you so much for taking time out of your busy schedule to come on and answer all Amanda and my questions, and to help educate our audience. Really appreciate you being here with us today.
It's a pleasure.
I'm definitely signing up for a consultation. So you have one new prospect.
See, and I already met my goal for the day right there.
Well, hopefully you're in one of my states, and I'd be very happy to.
Illinois. Are you in Illinois?
Yeah, I am the Illinois guy.
Yay! All right.
Well, it's been a lot of fun. I appreciate the opportunity to talk to you too.
Keep doing what you're doing. I love it. What a great mission and purpose. So thank you so much. It's been a fascinating conversation with you.
All right, everybody, until next week, please remember to take good care of you. Bye-bye.
Bye-bye.
Well, that's a wrap for this week. Thank you so much for joining us. We're so glad to be here with you.
And just remember, we're here to serve. Reach out, connect with us on social media platforms, and dig in deeper.
Yes, all those links will be in the podcast show notes. So join us. We can't wait to continue the conversation with you over there. Until next time, everybody, take care.